Thank you for everybody joining. For those seeing us, the recording, I hope you're good whenever you see this recording. I'm Liz Marie. I'm the Programs and Event Liaison from LMSA National, and I want to thank our Canopy partners for setting up this talk and talking about us about International Mother Language Day. I hope everybody enjoys it. And for any questions, please feel free to use the Q&A option in our Zoom link in our Zoom settings or drop a message in the chat. Take it away.
Wonderful. Thank you, Liz Marie and Chris, and all of our friends at LMSA for co-hosting today's session. And we really appreciate the opportunity to work very closely with the Latino Medical Student Association on this important occasion, as well as the initiatives that we'll be sharing later today. So welcome everybody to our celebration of International Mother Language Day. And today's title is Honoring Heritage and Empowering Advocacy. And we appreciate everyone who is joining us. As healthcare providers or future physicians, you know that medicine is more than just biology, it is a deeply human exchange. It relies on mutual understanding. When a patient can speak the native language, they're not just communicating symptoms, they are expressing their identity, their fears, and their trust. So today we'll explore why language concordant care is so important. It's not just a convenience, but a critical necessity that improves outcomes, that builds trust, and that ensures that no patient's story is ever lost in translation. So thank you again for joining us on this important conversation. And we'll also share a preview of an exciting initiative that we're collaborating with LMSA on, the Scholarship for Access to the Canopy e-learning platform for medical Spanish. So I'm Bill Tan. I'm the founder and CEO of Canopy. I have the distinct pleasure to be working with my colleagues. I'll be introducing them in a brief moment. Eden Staff Strom and Dr. Drew Bhattacharya, who will be joining me today as co-panelists. So a quick introduction about Canopy, as some of you may already be familiar with our medical Spanish e-learning course. Some of you have also been using our Canopy Speak mobile app. We are working on a number of ways to support providers and students and organizations like yourselves to overcome the language barrier, to eventually be able to eliminate the language access barriers and improve quality of care. And in addition to the e-learning platforms, we have a QBS qualified bilingual staff exam to help confer the credential for those who are fluent in a target language. And we're also working on a number of very exciting initiatives to bring these tools to the clinical sphere to help the live conversations between providers and clinicians. We'll be making a number of announcements later this year, and we welcome any of you to reach out to us if you have an idea on how we can improve language concordant care or have ways that you would like to explore to make the language barrier less of a concern. So let me actually first start with Eden. Eden, you come from a very unique background, being not just a linguist, but also have at one point worked in the medical interpretation space. Could you give us a quick overview of your background and also share with us what comes to mind when you think about International Mother Language Day celebration?
Yeah, absolutely. So I'm a linguist, which necessitates working with many languages, but my PhD is in Hispanic linguistics. So that's a huge focus of what I work on, especially for Canopy. Spanish is just so important, especially in the States. I also have had the privilege to work with many marginalized or endangered languages, including living in rural Bolivia for some time, working with Quechua, Aymara, and Guarani down there, and also working with some Amazonian languages as well. And now in my work with Blossom, which is another transcendent platform, working with the Anishinaabe people in their language revitalization efforts as well. So I'm very privileged to have worked with so many different groups. When I think of International Mother Language Day, to me, it's kind of got two sides to it. Um, one almost tragic and one absolutely celebratory. So the onus of the holiday, the beginnings of International Mother Language Day, came from a protest by Bengali students in 1952, I believe in Dhaka, um, trying to advocate for inclusion of their language, and they died in their efforts. And now they are immortalized in this day, and the importance of inclusion of diverse languages and access in different languages is more widely valued now. I think this is an important element to the day, especially when we talk about language access for marginalized communities, especially in the healthcare space, because there are people who are still dying for their language to be included, right? And this, unfortunately, is something I have seen working uh, in language access and in interpretation, that this hesitancy to come in because people are unsure if their language is going to be included or that they're going to have enough access adds a barrier to accessing healthcare itself and can lead to serious complications. So this is a very, very crucial issue. On the other hand, of course, much time has passed since the 50s. We've grown a lot. We've come to value diversity, and celebrate different languages. And I think that's an equally important side of this holiday, is celebrating the beauty of all of these languages all around the world.
Thank you for sharing your perspective there. There's a lot to unpack, Eden. We're going to circle back on some of the themes that you have brought up. So, Drew, please give us a quick introduction and also what is your take on the celebration of language diversity and the International Mother Language Day occasion?
Right. Yeah. Thank you, Bill, and thank you to the LMSA for having us here today. Dr. Dhruv Acharya. I'm a population health researcher and professor. I've served as faculty in schools of medicine, nursing, and law. Also served as an executive of a couple large health systems where I oversaw the language services department, part of my broader scope of work. And I've worked with many community health organizations to address health disparities in underserved communities. I currently serve as the head of grants, research, and content here at Canopy. And in terms of International Mother Language Day, as a Bengali, I have family from those regions where those student protesters were killed for speaking up to preserve their language back in 1952, and which later inspired the creation of this day. So that hits home very personally, and it's inspiring to see their legacy honored and continue. And so I'm very thankful for Eden for bringing that up, and for LMSA for that opportunity. Closer to home here in a professional context, internationally, we find explicit protections for language access in many international instruments, such as the Universal Declaration of Human Rights, as well as the International Covenant for Civil and Political Rights, which the United States has actually ratified. And both of those emphasize non-discrimination in the treatment of people on account of their language. And so what's interesting is that we find the spirit of that and of those protections reinforced in national laws like the Affordable Care Act, as well as in state laws. And although there's some variability with respect to the precise, parameters of all of that, together they kind of speak to that proactive spirit of meeting people where they are and ensuring that, notwithstanding in some of these protected classes or barriers that they may face, that they're able to receive the same care and treatment and access to resources as anyone else. And so for me, that's very inspiring and hopeful, and kind of looking forward to reflecting on that in the context of our healthcare industry and some of the experiences that Eden and I and Bill have kind of had over the years. And again, thanks for having us.
Wonderful. And Drew, since you just brought up the Affordable Care Act and the notion of creating a qualified bilingual staff designation, QBS, actually stemmed from that legislation. Is that correct?
Yes, in part. And so Let me begin with this. Every even the most well-intentioned law or hospital policy can't contemplate every opportunity to improve care. And so what's so important is that we really when we talk about the scope of the ACA and the broad requirements is really think of them as a launching pad, a way that we can secure meaningful access to care by ensuring that language isn't a barrier. That's the broad mandate. And historically, that has been done in two parts. One by that emphasis on access to medically qualified interpreters, such as like Eden, or qualified bilingual speakers, or QBS, as you point out, Bill. But there are many other kind of facets, to the ACA and the requirements, and yeah, happy to expound upon that, as we discuss here now or later. But certainly, I think the QBS pathway is such an essential and overlooked part of that opportunity because historically it's been difficult to track. And there hasn't been a singular standardized way of doing it. And that's where organizations that support that and offer tools to kind of advance that, would be welcome. But health systems, and now speaking from my former life, we've had challenges in really understanding, what are the standards that ought to be met? How do we put people on a path to actually secure enough to feel that they're able to confidently engage their patients at different moments? Where are those needs the highest? How do we plan it out? As you said earlier, Bill, that this can take a long time if it's not done very intentionally. And I think those are some of the challenges when I think back as a leader in the healthcare space that we've faced. And unfortunately, in the face of that kind of uncertainty, it's kind of easier just to regress to the mean and to think, all right, how do we just ask for more money to secure more interpreters through external vendor? And that's not always the most appropriate kind of way of thinking to address these issues.
And as you've pointed out, the legislation puts a spotlight on qualified bilingual skills and have raised the profile of this destination, the QBS destination, but actually left the definition of what constitutes bilingual fluency or qualified bilingual fluency open. And to some degree, that is really where a lot of the conversations and the collaboration would need to come in between the institution that needs to set those thresholds to qualify the bilingual staff and the staff themselves and the pipeline of training and cultivating the bilingual skill. Just from that perspective of having been in that position of authority to help the institution determine these thresholds, determine these credentialing mechanisms, can you speak to the kind of effort, the kind of collaboration that has taken place, that still need to take place to make that skill set become even more visible and more recognized?
Sure. I mean, I think that, there's different motivations for keeping things a little ambiguous at the legal level. And one is in deference to the fact that these are not always subject matter experts. And so they don't want to create a situation where something is too rigid so as to prohibit, opportunities to advance the competencies. On the other hand, I personally have seen, at least at the major systems that I've interacted with, more of that effort to look at the standardization as it comes to interpreters, less so QBS. And I think part of that is because of the challenges and maybe the lack of more national standardization, or because, as you just pointed out, the fact that there aren't those parameters spelled out in something that could be nationally recognized. And the important thing to recognize is that's not deference to the patient, right? That's not deference because there are those kind of explicit, prohibitions against using a family member in lieu of a qualified medical interpreter. And if you are going to refuse an interpreter, if you have limited English proficiency, there is the need to execute that kind of refusal and have that documented. So there are already a lot of kind of legal parameters in place to ensure that the healthcare provider is also making note of that. And they can also, as a matter of fact, even in the face of that refusal, still ask for an interpreter to be present. So there's a lot of safeguards in place. And of course, when it comes to trust building, when it comes to making the patient comfortable, it stands to reason that if the provider themselves, if the clinicians themselves are also competent in those language skills to meet the patients where they are, we've seen the evidence, we've seen those kinds of studies that have showed that higher trust and engagement by the patients themselves. And so that itself is very encouraging. And a brief aside on that, There has been a lot of empirical studies in the language access space that have not been shared in terms of the awareness among many health professionals. And I think that's an opportunity as well for all of us here, because at the end of the day, we're also scientists, and it's important that we share the results of many of these studies have been done. And some of these studies, they're seminal studies from 20 years ago. And there hasn't been as much traction as of late. But those are great studies that have been done that have spoken to the association of language with patient safety and quality, access to care generally in certain geographies. And we need to do a better job of socializing that.
Yeah, some of those statistics have been really eye-opening to me to kind of go from working as an interpreter and then now as a researcher to see those statistics have been a real moment for me. One in particular that stands out to me is um, out of Spanish-speaking patients, Spanish-speaking LEP patients, those who were satisfied with the language access they were given versus not. The rate of dissatisfaction is relatively high. And this is shocking to me because Spanish is such an integral part of the United States, right? We have more Spanish speakers that live in the United States than there are Spanish speakers who live in Spain or Venezuela or Argentina. The only one who's got us beat is Mexico, right? And with our history going back in that language, so many states that spoke Spanish before English even. You can argue we're a Spanish-speaking country. Our healthcare system just happens to be in English. So if Spanish-speaking patients are not satisfied with what they're being offered, how much more are speakers of every other language suffering, right? The work is laid out for us for sure.
I appreciate you bringing that up because I think all of us are moved by stats when they're kind of close to what we have our biases towards across that entire continuum of care, right? So let me drop a few more and see if they resonate, with some of our viewers. One that stood out for me, so I'll start with my own bias. I did my doctoral studies in patient safety, and so to realize that LEP patients were experiencing 20% higher rates of physical harm from adverse events compared to non-LEP patients was shocking to me. Historically, I've been aware of the patient experience differentials because I used to stratify data by that because I used to work closely with that department, but not as much with patient safety. And so when I began to work closer with patient safety and I did more research in this area, that was one that stood out to me. Another one for those of you who are curious also about the inpatient stay and communication. LEP patients have been shown to have upwards of 1.5 to over 3 days extra inpatient stays compared to non-LEP patients. And it's not simply because of, the time of an interpreter being present. That's kind of the illusionist step, but that's not always the case. Another one that sticks out to me is there's somewhere between like 15 to 20% higher rate of 30-day readmissions after discharge. So those are just a few, on top of what Eden had shared, and we can do better in this space. But to close those gaps, should be part of our short-term and our long-term efforts when we think
Right.
about these are metrics that we look at a system level for all patients. Why are we not looking at it and stratifying it by some of these areas which identify clear opportunities to do better across that continuum? And I think this is just a great example that, like for myself, as an executive, I need actionable data. And so certain complaints are helpful because they allow us to address that patient singular concern. But if I can see the population, level data, then I can get a little bit more buy-in cross-functionally to address things further upstream and across, all the different departments that might be implicated.
I want to take one moment to zoom back in from population to individual, and then I'll let Bill ask us another question. Just in that these statistics are deeply meaningful because they say so much, but the people who are implicated in these statistics are people who are experiencing these statistics in real time in a healthcare setting, which is a lot. That's important to recognize. And I see some of these stats you talk about, kind of more difficult outcomes for LEP patients in all of these different scenarios. And I saw some of this on the ground, right, interpreting. One of the common issues that we had was people being hesitant to come in, either because they were afraid that immigration papers would be asked for, they were not sure about what language access they had, or cultural misunderstandings. This was interesting because we had great on-site interpretation, yours truly, among others. And we had a highly bilingual staff as well who could help as well. It was interesting to see how they resolved the prenatal treatment issue. People would not come in for prenatal appointments. It wasn't seen as necessary. It was seen as risky for all the reasons that I just mentioned. People would avoid coming in, and ultimately they would come on the point of going into labor and have really dangerous situations as a result. And what had to happen was more learning by the staff who were already bilingual or spoke some level of Spanish, most of them. But that wasn't enough. They really had to get to know this population, understand this culture, train for this specific scenario and what they might need to say to assuage these fears in new mothers. And ultimately, they ended up solving this problem. People were much more willing to come in for prenatal issues. But it does take that level of humility, even among bilingual staff.
And the kind of diversity that you are alluding to, Eden, in terms of the number of languages that are spoken here, even the dialects within the Spanish language family that is used every day, and also the diversity amongst our patient population, their backgrounds. You're actually working on incorporating those elements into the e-learning curriculum and making sure that the simulation capabilities inside the Canopy platform offers access to those patient profiles and the case scenarios that are being utilized to help our learners practice teach back, practice empathetic communication, get to benefit from those diverse elements and aspects. Could you speak a little bit more to how that is going, how that's coming along, and how users can take advantage of these simulation capabilities on our platform?
Yeah, absolutely. So this is a feature that has been repeatedly asked for, and I'm very, very excited to be on the precipice of putting it out. Spanish is an incredibly rich language. I knew a doctor once who did some work in in the Peruvian Amazon, and he worked there for several years. He would go and do trips there, medical, volunteerism type trips, And then one year he switched it up and he went to Cusco, which is also Peru, um, and he couldn't communicate. And he asked his interpreter why he couldn't communicate, and they said, "Well, you're speaking Amazonian Spanish. We speak Cusco Spanish." And he was blown away because it was the same country. But that's how rich this language is. And it's just absolutely crucial to prepare speakers to converse with different dialects and different regionalisms and different kinds of Spanish. We have built out simulations for interacting with virtual patients, and each virtual patient has 32 layers of customization based on significant research and bodies of literature. So this is not only where they are from. Do they speak Spain Spanish or Dominican Spanish? And anyone who knows anything of either of those varieties of Spanish knows those are incredibly different, right? But also, how old are they? Right? That makes a difference as to how they speak, right? And we need to be able to treat a teenager just as much as a 65-year-old, right? And beyond that, what's their health literacy level? What's their education level? All of this is going to determine important elements of communicating with these patients and represent the real breadth of experience that you come across in the clinic, and that's important to address.
And many of the audience members who are here today are working on improving their bilingual fluency, looking to attain that QBS credential down the road. Could you offer some tips and practical guidance on how one can prepare more effectively towards that QBS exam and how to continue their journey, even if they have already reached a certain level of fluency?
Yeah, absolutely. You would not believe the number of people that have come to me and told me, I'm just not a language person. And you know what? Every time they tell me that, they tell me that in a language. Usually it's perfect English. And I said, well, you seem to have mastered at least one language. The human brain was really built for language in so many ways. You can't isolate where in the brain that it is stored. It's all throughout, right? You use your whole brain. The thing is that we never were evolved to sit down and learn it out of a textbook. Um, we were meant to learn it in community, right? And so you have to kind of take it back to that naturalistic approach, right? Like I mentioned, the simulations, absolutely key to have real conversations. And we not only offer simulations, but also stepping stones and tools to use kind of phrase-based communication in real time with real patients as well. So that's incredible. There's another component there that's important to note with adult language learners, though, however, which is the affective filter, which is um, a process by which it is more difficult to speak fluently, especially in a language you are less sure of yourself in, if you're nervous, if you're anxious. Your brain goes into that fight or flight. If you were to fight a bear, you wouldn't need that much language. And so you kind of shut off those parts of your brain. And this happens in your first and second language. Often people will feel tongue-tied when they're speaking in a presentation or an interview or something high stakes. And so to account for that, we have games to scaffold up to these more naturalistic interactions. So this is not a factor, and you're able to perform at your highest level and really take in the language as you go.
Wonderful. And we'll touch on the scholarship opportunities in a moment and discuss how we can make these resources available to the LMSA membership and to the broader healthcare practice community. Before we do that, Drew, I want to circle back to a point that you brought up in terms of the impact of language access, language concordant care on the downstream outcomes, the patient care outcomes, such as length of stay and 30-day readmission rates. And you alluded to the fact that some of the evidence is very encouraging, but they are dated, and there's the need for more research. What are the calls to action or encouragement we can offer our audience members here, especially the next generation of healthcare leaders and practitioners, to rise up to that occasion, to engage in scholarship, research, and help us establish those relationship, the connections between improved language access, better patient care, and even financial performance for the institution?
Sure, a great question. Let me answer the question kind of building off that kind of customization necessity that Eden spoke to. There's at a high level, there's two aspects of language access. One of them is what we invariably spend our time talking a lot about, and that is about how do we get that interpreter or that QBS present so they can convey information to the patient. And that's certainly a very important part of it, because that's what we do in healthcare. We diagnose, we treat, and we take care of patients. But the other side of it is also having that humility to listen to the patient, to meet them where they are. So Eden spoke about all those different kind of 32 different layers and the different customization. And all of that is part of that half of it, that half of listening to what they need, what their concerns are. And truly, in both a legal and an ethical context, it's about honoring that patient's right to self-determination and having that agency over their own care and matters affecting their own health and their body. And so to do both of those things, to have that framework of saying there's information I'm going to give and communicate to them, but there's also information they need to be comfortable communicating with me. If you come into the into the space with that humility, you're going to identify many areas of improvement and calls to action that you can do across any part of the continuum of care. And so whether you're involved, in things further upstream from pre-arrival to arrival or downstream once they're inpatient or even right before follow-up, discharge and follow-up, there are opportunities for you. And so, very simple ones like pre-arrival, looking at the web page, is it available in preferred language with embedded materials that are accessible as well. Once the patient's arriving, are we having a timely assessment of their needs in that preferred language that doesn't compromise an accurate diagnosis and the treatment that goes along with it? And for our medical students, think about the ED and the importance of assessing that treatment window particularly for emergent treatments if a patient's had a stroke, and being able to recognize that if I'm not getting that information accurately from a spouse, family member, whoever it is that is accompanying the patient, then how will I know if they're an eligible candidate for the appropriate treatment? And there have been many specialists who've spoken to that importance of having that communication barrier overcome so they can treat them appropriately. Once they're inpatient, how are we accommodating those unique needs? As Eden mentioned, it could be their culture, it could be their diet, it could be their religious beliefs, could be a host of other things, and recognizing that the follow-up should not just be about the vitals, right? Of course, that's important, and you want to do that, a couple of times a day while they're in patients. But beyond the vitals, right? What else are we assessing? And then, of course, with the discharge, I'll give you a very simple example. When I was doing more work with patient experience and patient engagement, I was blown away. They had listed for me 20 best practices and said, these are the things we can be doing to improve engagement, communication that are associated, Bill, with those downstream indicators that you mentioned. And for any one of those practices, there is a service, there is a CPT code, reimbursable opportunity as well. So there are things we can be doing to effectively care for our patients, and it's a win for everybody. The irony of it is that getting caught up in just the enumeration of all of those things, sometimes you're not doing any of them. And so just think about, if you take that list, what's one thing we can be doing tomorrow that could help that patient's communication? Maybe it's the signage of Ask Me 3, put forth by the IHI. Maybe it's an experience like Teachback, one of my favorites, which is often used. Those are best practices that have been empirically studied with an effect on health. And so, Teachback, one example where we know it's associated with a 23% reduction in those 30-day readmissions. So we can look at that as an opportunity to say, how do we, inculcate this into the workflow? Now, that said, there are real barriers to doing some of these things, patient volume, maybe even budget constraints that I've faced in having an interpreter present, even at that downstream phase. So what are ways that we can have workarounds, by resources and other things to address that and to really embed the best practice within the communication workflow? And so it begins first with that honest assessment across that continuum of care. And then you can start looking to the resources and the opportunity to track them. And you mentioned, of course, the financial repercussions beyond just the documenting of the services, certainly for the billing purposes. These are associated with real savings in those macro level outcomes. That's why hospitals track LOS. That's why they track 30-day readmissions, right? It's not just because it's good for the patient, certainly, but it's also important from a financial perspective as well. And so being very mindful of that and sensitive to all of those kind of considerations is part of this process for us. And so, yeah, we're trying to do better, in researching and looking very carefully and precisely at what those levers and drivers are. And we're very confident that we're at an inflection point, I would say, because the body of research that has been done is truly was shocking to me, as I came into the space, because I did not even know how much had been done. But there are also many opportunities to do better and do more. And so looking forward, to I think more collaboration between folks from different spaces, even as diverse as Eden and myself, working with interpreters and pop health researchers and thinking creatively of how are ways that we can assess language competency and communication, and how do they tie to those downstream outcomes and other non-clinical metrics, that support both our our clinical staff as well as our administrators as well.
And both of you have really touched on a bigger point, which is the bilingual skill set, the support for language concordant care shouldn't be an individual effort. Yes, our individual activism matters a lot, but language access and bilingual training and the funding for language services needs to be an institutional priority, just like they're being supported with the same degree of seriousness as any other patient safety program. And we need medical schools and hospitals to really step up and invest in the pipeline to make bilingual skills development a supported pathway, and then shouldn't be a out-of-pocket expense for the individual practitioners or even much less so by the students. So this also brings us to the initiatives that we're collaborating with the LMSA friends on. And I'm going to ask my colleague Beck to put the slide on the screen. And I also want to invite everybody to feel free to put your questions in the chat box, and we'll hopefully get to all the questions. And there will also be contact information for you to reach out to us even after the webinar in case we don't get to your particular questions. So this is an exciting initiative. This is a scholarship offer for LMSA members who are interested in learning medical Spanish. As part of the collaboration, we'll be making licenses available free of charge to a number of LMSA members to get access to all 4 levels of the Canopy Learn curriculum, including foundational medical Spanish and levels 1, 2, and 3. And for those who are interested in attaining the QBS Qualified Bilingual Staff credential, we'll also be making the practice tests and the QBS exam accessible as well. So in order to apply, there is a very brief prompt that we have collaborated with LMSA to tailor, and it really gets at that activism and advocacy that excuse me, that we want to encourage. So on the screen, you see that the premise is you are on a special mission to make healthcare more linguistically competent. And because of your strong vocal advocacy, your school's leadership has come to you to represent the medical school to interact with a hospital partner. So the hospital is looking to encourage student activism and leadership, and they're willing to put aside some funding to support an initiative. So it's up to you to decide what that initiative should entail, what a project might look like, and what the success look like if the project achieves its goals, and who you would invite from the hospital side to be at that conversation and why. You could either submit your pitch in a one-page write-up or in a brief 3-minute video. I believe the application is already live on LMSA's website, and we look forward to hearing from all of you if you're interested in applying. And also, the activism is not limited to just learning medical Spanish or utilizing the Canopy ecosystem to do so. We welcome any ideas and any creative solutions that you want to propose. Just like my colleague Drew and Eden have brought up, there's so much work that remains to be done. There's so much scholarship and so much research that can be undertaken to really flesh out the evidence base to establish the connection between multilingual access, better patient care, and better institutional performance. So at this point, we can take a look at some of the questions that have come in. There's a question here about what is in the Canopy curriculum, and should everyone start at the foundational level, or there's a way to pick a different starting point based on your fluency? So Eden, I'll let you give us your insight on that one.
Yeah, absolutely. So Canopy is a really multifaceted platform composed of several different technologies. We recommend starting out with Canopy Learn, which is a structured introduction to the grammar and vocabulary most needed, according to comprehensive research that we've done, the most needed communicative skills for medical professionals. There is no wasting time here. You're not going to learn the, my mom has two hats kind of happy nonsense that happens in other classrooms. We're going to get right down to what is most needed, real phrases that you can use in the clinic today. And then moving from there, we recommend a shift to Canopy Learn, which is a more flexible approach. It's a playlist based. So you pick a playlist based on what specialty or rotation that you're working on right now, what interests you have, what typical conversations you find yourself having. You can work through phrases related to that, play games. There's a series of 4 games that scaffold up to having real naturalistic conversations with, as I mentioned earlier, the multifaceted, multi-layered simulation patients. And you can try out lots of different ways to have those simulation interactions. You can just go in blind and just see what this patient has going on, right? Just like someone might just walk into a clinic and present with whatever symptoms they've got. But you can also practice really targeted communicative skills like teach back, as Drew mentioned, or motivational interviewing. So that's really exciting as well. You do not have to be a specific level to start anywhere. We have placement tests built out for general use or for specialty use. And we will place you as needed. It's really important that Canopy, as a whole journey from the beginning in Canopy Learn all the way up to our Canopy credential, which is where you can prove that you are a qualified bilingual staff member, that all of this is available to anyone starting from any point. So whether you've never spoken a word of Spanish in your life, we've got you. If you're a heritage learner and you're perfectly comfortable talking to your family members but have not used it yet in a medical context, absolutely no problem. If you took Spanish all the way K through 12 and just kind of want to touch up some stuff and get less academic, more real in your vocabulary, that's also totally reasonable. We can place you um, where you need to go.
Thank you. And a question came in regarding what's the timing for the submission for the scholarship? When will the winners be selected? I believe the process will take until sometime in April. Our colleagues from LMSA can confirm for us later on, or I'm sure it's on the website as well. I believe the winners will be announced in April. And the related question that's raised here is, I've been thinking about signing up or learning medical Spanish. Should I wait um, till the winners are announced? And also, we have another question about whether if someone has already signed up and is already using Canopy's products, can they still apply for the scholarship? And the answer is definitely yes. And as we all know, and Eden's alluding to, the longitudinal nature of learning a target language is never and there's never enough time. So if you're ready to start your learning journey, please don't wait. And if you do become one of the selected winners, it will be available to you for your second year. And we'll be looking for ways to make even more resources available down the road. So don't let this opportunity to participate in the scholarship hold you back. And also, we're looking for student leaders and advocates to step up and tell us what kind of initiatives and projects are worthwhile out there. So even if you're already using our product or any other resources, we still want to hear from you in terms of that creative solution that you want to see being implemented.
Yeah, this is a huge opportunity. The reality is, as we mentioned, that we are not meeting as a country, as a healthcare system nationwide. We are not meeting the language access needs that are before us, and those language access needs are growing. Every medical student who completes the residency, who passes all their boards, they will all be doctors, right? But not all of them can meet this specific need, have this specific skill set, which is absolutely an enormous advantage to have documented as you move forward into the job market. So we would be very excited to add this scholarship to your resume.
Yep. And we have a question here about whether schools that don't have a strong connection to Canopy can also get involved. The answer is absolutely yes. We would love to hear from you. And the scholarship is limited to LMSA members. So if you're not already a member, this is a very good time to get involved with the wonderful organization. And we work with a number of medical schools, residency programs to make the Canopy platform broadly available to all of their students, to all of their residents and faculty members as well. So if your school is not already a Canopy partner or customer, please reach out to us. There are ways for us to work with you and your leadership at the school, at the hospitals to make it available. We would love for the day when language access resources, whether it's for live communication or proficiency training, is broadly available to anyone who wants to access it. Students, individuals shouldn't have to bear the burden for a barrier that is, by no fault of their own, something that they have to address. We have another question here. Is the QBS exam generalized across LMSA or is it institution specific? So Drew, I'll let you give your insight on that. And I think you alluded to some of the aspects of how the QBS designation came about and some of the institutional efforts to try to make it a established practice.
Sure. If I'm understanding the question correctly, it's whether it kind of carries over, after the kind of certification. Well, absolutely. I think the more important thing to realize about the QBS designation when it's achieved with respect to that competency is that it's not being an interpreter, right? It's really in caring for those patients under your care. And so the QBS designation does not give someone that kind of license or recognition to be Eden. They can't just go and be serving as an interpreter for other people's patients, right? That's not appropriate. And so they have to be within that ambit and scope of care when it comes to that. So certainly, there are those competencies that that Eden alluded to, but it's very important that we recognize that in the context of caring for one's own patients, and that's kind of where that those boundaries are set. Beyond that, there's more ambiguity, of what those precise distinctions would be. But again, the way they kind of care for that is to recognize that you would have to achieve that kind of qualified medical interpreting designation, and there are different national standards for that, different tiers that one can achieve. Different systems, in my experience, have taken either a very lax approach to those standards, and others have actually looked to the tiered structure that some of those bodies have put forth to say, okay, if you're bronze or gold or platinum or whatever the designation they have, they want their interpreters to achieve a certain level. Many systems I felt in just general practice, we're still in that transition phase where some people have been at this job for decades. And so they've just acquired a kind of heightened proficiency, without getting any kind of formal recognition. And so I think it might still be a while before we see some of that codified, into particular laws or policies. But so long as one keeps in mind, that very important distinction of the authority the opportunity to communicate with one's own patients that are within their care versus the opportunity to translate and serve as an interpreter for somebody else. And, that's the most important distinction.
Yeah, thanks for that clarification. And I'll add that the underlying QBS exam is standardized. In our case, the Canopy credential exam is the same one that any healthcare organization can utilize to credential their staff members, and it's a psychometrically validated test. The variability and the flexibility comes in the institutions get to set where the thresholds are for qualifying their staff. And we've been talking to some hospitals that want to have a two-tier system, for instance, one tier for medical professionals who engage in clinical interaction, and then a separate tier for non-medical conversations, such as those conversations that happen at the front desk or with the call center. So there's flexibility for the institutions to determine how they want to establish those thresholds for credentialing. And we'll welcome anyone who has more questions or even immediate needs for introducing the QBS credential to the institution to come forward and get in touch with us. So we are at a really good point to wrap up. We thank all of you for joining us today. We want to thank our colleagues at LMSA again for hosting today's session for this celebration of International Mother Language Day. And we look forward to hearing from you through the scholarship application process. And also don't hesitate to reach out to us at any point. Have a wonderful evening, everybody.
Thank you so much.
Thank you.
Thank you, everyone. That was great. And for everyone joining us, we'll send the recording later in the week. And for those joining us virtually or later, thank you for your attention. And any questions, just send an email. Thank you, guys.